wanted to get in touch with you because you have a lot of very valuable experience, and you have been working as a health facility in charge. You have been working as medical superintendent, as the in charge of health sub-district, district health officer. You've been on various consultancies with WHO, UNICEF, and so on. And now you're the program manager of EPI at the ministry. So you have, or at least I assume that you have a lot of deep understanding of the healthcare system and the processes, because you've been both on the ground and you are currently at the decision-making level. So I just wanted to use this opportunity with you and ask you about some of the bottlenecks that you're currently facing and that they're standing in the way of effective EPI program in Uganda, that you think that should be brought into the attention, because what we're really trying to achieve is to educate and bring the awareness of what is really happening on the ground and what should not be just left out and should be more focused on when it comes to strengthening healthcare systems.
Okay, some of them are, I think, in terms of policy, we are there. For example, for immunization services to be effective, you need to make sure the services are available to people where they need it. So availability will require that a health facility, should have a fridge, so that when people walk in, because the facilities are near to people, so when they walk in, they should be able to get the vaccines. So that is step number one. And not all of, about 2,000 health facilities do not have vaccination services. So that defines the need to invest further in cold chain. Number two, we want to have vaccination services carried throughout the week, every day. But this also is constrained by other things like staffing. The staffing requirements in health facilities do not allow this to happen as we would wish. The staffing in health facilities, either by structure, is inadequate, or by recruitment in health facilities to do that. So find that the facilities, some days, they do not vaccinate on other days. But what we are pushing is, if you were doing once, it twice. If you are not doing, can you do once? If you are doing twice, can you go thrice or 4 times? This is in the spirit of going towards the daily increasing service availability. We want the services to be an effort. We like to see an effort from every facility towards increasing the numbers of days for which they do. Then we also want to strengthen the screening of children for immunization in every outpatient department to reduce on missed opportunities.
By missed opportunities, you mean those who are 0 dose and those who are under-immunized?
Yes, but basically it is about children who were due for immunization, but they didn't get they had an opportunity to be in a health facility. They were brought for other reasons. they were not given vaccines, although they were already in the premises.
I
The
see.
parents reminded that child now, although you brought him because of diarrhea, the child is actually due for immunization. So get these medicines and pass through the immunization point.
Mm.
And for
So
this to work, it means the service has to be
it's
available.
more about integrating the health services. So
Yes,
exactly that you don't miss on that opportunity of having the child
yes,
vaccinated.
yes,
Mm.
yes. You see, the statement on integration is already there as a policy position, but we would like to break it down for the health worker to understand what it means. Because if you throw the word integration at them, not everybody will understand it, because it goes with the understanding, it goes with the responsibility.
Mm.
But there are people who are tactical. Theirs is just a person has come, he has this complaint, let me resolve it.
Mm.
So for you to enlist everybody to think in that way, you need to embed your work into their work scheme, so that they know when I'm seeing a child, I should also check that they are fully vaccinated. Or if they're due for any vaccine, then that vaccine is prescribed the way you prescribe other medicines, so that the mother goes and gets the service. So this is about service organization, really. Then we are saying there are children who are far from these facilities. The parents are busy with other things. So can we, as the health system, respond to that need by taking the services nearer?
Mm-hmm.
So this is where the place of outreaches. So the outreaches, as of now, we are doing it from the health facility. We are going once to a parish. So the question would be, some parishes are big, the parishes are others are small. Can we mobilize in a manner that our mobilization effort reaches every village?
Mm. I know
So
that with the outreaches, it requires a lot of resource mobilization. You have to organize the transport. You need to make sure that the medicines and other supplies are available. So how does it work with financing of the outreaches? And how many
so
outreaches are there? Is it based on
and
some micro plannings?
yes, this is the detail which one has to address. You have to plan how which villages are going to be benefiting from this. So at the moment, our micro plan focuses at the parish level within, but one parish may have 6 villages. So how do we mobilize down to the number of, to the villages? How do we bring villages in the focus of our mobilization effort? That is the next question. And now to mobilize at that level, you need a lot of money. You need a lot of money. And unfortunately, when people who finance immunization see money going in that direction, they are not willing to put the money there, because the money is going in form of allowances.
Mm.
It is not an allowance for sitting down. It's allowance to move from house to house, is an allowance for the person to feed, is allowance for the person to live what he's supposed to do, and he's doing it. And it's not something which is profiting, except that the level is extensive and expensive. So if you don't invest at that level, using whichever model is seen to be affordable, then we will just be doing disservice to this zero dose stuff we talk about. But I don't see a different way to address zero dose unless you invest at that level.
And if you invest into this level, how do you make sure that those allowances, or how would you make sure that those allowances go actually for the expected outcome and for the activities? Is there any visibility or transparency of the transactions that have been made and the service that was provided?
So the health services here are decentralized. The districts are governments. Even the law and the sub-counties are governments. So at the national level, it is in our interest that the funds are accounted for. But the responsibility to ensure this happens is at the subnational level. So the challenge we're having right now with these approaches is these interventions should not be seen as a health. It should be seen as the lower local government intervention, so that the actors, the accountability for these resources does not need to be requested from the Ministry of Health. It should be the lower local governments. So the effort to make them understand that these resources are here, these resources are inadequate, but should be put to the better use, I think we are excluding that level, partly also because of the conditions attached to the resources. So my view is that at the moment, we do not have a clear visibility in the sense of the word visibility. But where we would want to invest to ensure that the payments are in such a way that you link payments to the work actually done, so that the law, and it becomes a tool for the implementers downstream to use in order to ensure that the funds are accounted for. And you see, there are two things there, and we need to be very clear on what objective we are pursuing. There's the objective of ensuring that funds are put to the best use. Is also the objective to ensure that results improve. I think when we talk about the funds, objective should be to see that the funds are put to the right use and becomes an incentive for people to move to the field and address the issue of outreaches in a way that they are focusing on reaching the 0 dose. But the payments will not be instant. I think what would improve outcomes is if the payments were done on the day of moving. If the payments were instant, I'm afraid the instant payments we may be very far from getting there. But what I see feasible is we can, in the first place, improve the accountability, and then the secondary benefit will be results. But instant payment is going to be far because other financial management systems are still much. Even if you digitize some processes, it is sitting on a manual process, and to still delay the timeliness of payment, which I think is critical for it to have a direct influence on results.
There was a RBF component that was implemented by World Bank, but it finished in June. The reason it finished, was it mainly because of this payment accountability where it took a lot of time for the health worker? I think it took over 3 quarters for the health workers to receive money based on the results that they have submitted.
Yes, that speaks to what I was explaining. Yeah. That the payment systems are not all digitized. The others are, for example, the payment may be digitized, but the process leading to it is manual. For example, if people are going to go for vaccination, you are not going to pay for the plan, you will pay for the action.
Yeah.
It may be planned that they will go to a parish once in a month. So if there are 4 parishes, you expect them to go 4 times in a month. But the actual thing may be that actually they did not go. They did not go in that month. So in terms of payment, you pay for the actual outreaches which were implemented. Now that actual count becomes a rate limiting step. Did they go? So it means someone has to compile and send that report. Now, when they went, have they sent you the right thing? You will have to validate. So these processes will still bog down the payments. But if we digitize and in a way that it builds the health system, when people go out, do their outreaches, once they submit their returns, a system which instantly builds the health system by connecting the results and the people who go to the payment system directly by presenting a bill, which then begins to accumulate. The health workers are able to know how much money they are expecting against their names. It introduces more transparency. And this is a model we worked on SPT. And I have also seen lack of interest, I don't know for whatever reason, from people whom we expected to be very enthusiastic about it. I see them, they talk of innovation, this is an innovation. They talk of digitization, this is a digitization. They talk of accountability, this is for accountability. Then I don't understand what we're all about. Yes, there's room for marketing. There's a room for promoting some products from certain countries. But I think what the countries identify as a solution to their headache should be paid attention. And this is really an area where we have worked on the concept, we have worked on the designs, we have worked on the tools, and it remains for us to put boots on the ground. But we need resources to do this because the attention on accountability is what all of us are interested in. It gives confidence, even within government, the pressures which are put on us about funds which are transferred and which are not used is very uncomfortable. So we are committed to transparency and accountability. But we would also want help in getting tools which help us to do this work. So the conceptualization on how this is supposed to work, we are past that stage. But we just need, the resources we need are not very many to put these concepts onto implementation. Basically, we'll need technical assistance because this is a new thing. We'll pilot in an area. I know there are lessons which will emerge. We need technical teams who can fix it from the technology side. And we want the process to be supervised so that the claims the claims are real and the payments systems respond to that need. All the stakeholders involved in payment need to be brought on board. And here, this technology is not substituting any government process. it is just, it is furthering the government policy position on e-payments. But e-payments which sit on manual systems will require more time for verification and others. And I think this is where the problem is. And this defines our next area of interventions. So the outreaches are the main theme for reaching the children, how they are identified. We believe that given the level of decentralization in the country, we don't need ad hoc structures. We also see people who are giving funds promoting ad hoc and temporary structures which weaken our. Yes, we are sensitive. Civil society have a role. We are sensitive. Other non-government agencies have a role. But if we substitute government systems using temporary and ad hoc structures which are dependent and which only show up when there is a funding opportunity, at the end of the day, we change the culture of the program, and we change the actors. And when the money goes away, the system will just collapse, unless that is the intention. So the people who are funding, at times I don't understand what their motivation is. Right now, the structures which we have and the approach we're having have put us in a very comfortable position where all antigens for childhood vaccination are now above 90%. And this is not the time where you want to substitute, because the systems which we're using right now have gaps, and this is one of the gaps we're talking about. How do we pay these systems in a transparent manner so that it becomes the culture and responsibility of those community structures which are institutionalized to know that they have a responsibility to ensure children are vaccinated and vaccinated fully. That is the last journey we need to move. And more importantly, this will also go with the issue of digitization of other EPI information. Because right now, working on aggregate data cannot make us reach all 0 dose. We'll move in phases. Phase 1 is the battle against partially vaccinated. This will do it by ensuring that those who reach the vaccination program are kept in the system, and we have mechanisms to track them. Phase 2 will be to work together with the birth regime to every child who is vaccinated is in our database for immunization. We start following them from there. This is the phase. So there are many things at the micro level that we like to focus on. These are innovations, and these are innovations which require funding, and the funding we're talking about is available in hands of agencies, individuals, and philanthropists, but we have no access to them, and that's our limitation.
You've mentioned this thing that I wanted to discuss more, which is the aggregate data, because the system, at least up to the last year in the EPI program, depended mainly on or heavily on aggregated data. And you often called it a faceless program. This is the term that you used, because you don't watch, you don't know the children, you don't watch their vaccination journey. You see them as aggregates. But then when you want to use the outreaches to reach those and identify those and follow up on them, making sure that they're fully immunized, then having aggregate data stands in the way, doesn't it? And I know that you've been working on the digitization strategic guidance on how to digitize the individual level records so that we have information about each individual child. So what do you think is the future vision of how do you reach 0 dose in Uganda, and how do you make sure that whoever is due for vaccine comes back on time and gets fully vaccinated according to the national immunization schedule?
So the point is we need aggregate data, not necessarily for the Ministry of Health. We need it for the actors at the operational level to know which children they're vaccinating, those who were expected to come, which ones have not come. And if they have not come to your facility, is it because they got vaccinated elsewhere? Or is it because they were visitors, they have moved? Or is it because the parents have refused? Or is it because the child maybe has died? This kind of information we don't know. And if we have to, all efforts to resolve this question right now is by mass action. You have to go blindly and you'll find it as it is there. But the digitization would make us have a more targeted inquest into this matter. So the process we started it in 11 districts, but the 11 districts right now, we have learned more about the tools we're using. We have improved the models. We need to scale this up. But in the beginning, we know that about 70% of children born in Uganda are born in health facilities. That's already a good starting point. Number two, we know that 98% of newborns ever reach the immunization point and get DPT1. That's already a good starting point. So so the first phase would be for us, the 98 who have ever come into contact passively or through outreaches and get registered into our immunization program. We work on that group so that the immunization program is concluded. They are followed up to the end to ensure that we minimize dropouts from the immunization program. The tools we have are able to help us do this. So what we need is the implementation of the tools which we have already developed, for which I said we need more TA and we need operational support. That is with respect to the partially vaccinated, and that is phase one. Phase two will require that we begin to deal with the 2% who never reach the immunization services at all. This now requires us to work together with birth and death registration, particularly birth registration. In this way, we will be able to get the children who are born and did not come to the immunization program. Because on the registration database, if the registration database is the same database for immunization, then we will see why children who are born are not showing up for immunization, and with the parents' information, you can finish it. Now, this I call it phase two, because that it requires collaboration with the Ministry of Internal Affairs, which has the mandate to do registration. There is already a collaboration in health facilities, but this can be extended to sharing the database. And that is the long term. But the immediate term is to perfect the system with what we have. And that is the journey towards reaching the 0 dose. Never mind what project approaches we want to have towards addressing this. 0 dose is a health systems question, and you need to address it through program development as opposed to project development.
I see. So when it comes to the registration, since we're using SPT in the EPI program to digitize the children's data, those are children that are coming for the health services. But do you think that in the future, maybe you could use those outreaches, you could use the community health workers as the extended arm of the health facility and register children at the communities, even without them coming for the service, but sending community health workers to do those registrations beforehand?
Yes, that's why you see when the policy environment has to be exploited carefully, because this is something in the mandate of another ministry. So the engagement of community health workers in birth registration and so on is something which we can do. It can actually be easily done, but it can also be easily misunderstood. So the second, to register the children at home, SPT can do this, but I foresee a resistance because there is a body mandated trouble. And let's start with what we are doing, and then we'll demonstrate this gap at an appropriate time, and then see how the two systems can collaborate. Because the SPT has the advantage of being deployed anywhere, and because of its appropriate technology, you can deploy it seamlessly anywhere into any environment, because you do not necessarily require heavy investments in that process at the subnational level, at the village level, which is very expensive. So it is possible and it is cheaper, but it requires buy-in beyond the Ministry of Health.
I see. It requires the collaboration within the ministries and the Ministry of Internal.
It's a policy, it is a stakeholder management issue.
I see. Dr. Alfred, your connection is dropping off a little bit.
Yeah, I'm on the road, so when I'm in a valley, it changes.
But I think this has been great to understand a bit more what are the headaches in EPI program and what stands in the way of its effectiveness and in some of the global issues in health strengthening as the zero dose or as the financing accountability. So yeah, I really...
This is a health systems issue. This is a health system strengthening issue. And the systems, the policies, the systems, and the incentives have to be aligned to ensure that we have a stronger immunization system that can reach the zero dose children seamlessly. It's a way of doing the business as opposed to an ad hoc arrangement which makes you to reach the zero dose with a lot of external propping. And once the support moves, you find that the things start collapsing on you. Then you need another project to support it again.
Yeah.
In this way, it is very exhausting. It is unnecessary because the resources which we have can actually do this with ease.
I see.
And what we have talked about here, I can tell you, if we got something like $2 million US, the transformation will be amazing. Because right now the gap we have is in technical assistance. We have equipment to cover the whole country. We have resources to bring the papers. We have resources for training the healthcare workers. What we need is we need technical assistance on the side of technology. People who can support us troubleshoot, people who can help build the capacity of the health workers, people who can troubleshoot, and people who can take observations to improve the system. And this is a way of supporting the vendors of the system. And this is where we're lacking.
Yeah, and I think it's very important to bring the awareness of this, of what is happening on the ground, where are the gaps, so that the decision makers, they get involved, they see it, and they could do something about it, bring the resources to make this possible.
Yeah, that is true. But what I see is the people are fighting for space.
Mm.
There are people who have got products, they're fighting for space, they're marketing their products, and they're not listening to the choices, and the decisions of those who are supposed to use it. So we see a lot of pushing of technologies down our throats with the limited benefits.
Mm.
A system which is technology heavy, I can tell you Uganda is not ready for it, particularly for immunization, because immunization is not a program which you run in air-conditioned offices or offices with sockets, in rooms. We vaccinate in communities, we vaccinate under trees, we vaccinate in non-conventional settings. We use health workers with basic training who may not be technology savvy. And the digital divide, which is big, cannot be ignored when you want to use technology to address a service like immunization. Immunization is the only health service with the deepest penetration. So when we're talking about immunization services, our focus are beyond the parish level. But many of these people are talking about hospitals, they're talking about district, county. That's not where immunization is done. It is done in villages, it is done under trees, it is done in schools, it is done in sub-county headquarters, core compounds, it is done in football pitches, it is done in front of markets, and it is done where there is no internet. It is done. So any technology which comes with those encumbrances is an enemy to the program, because we understand it. So that's why SPT provides the best choice for us, because it preserves health workers' skills. You do not require additional training in IT. You do not require to be charging. You do not need additional papers, because the papers you're already having. Registers will be in the registration forms. Tally sheets are the same tally sheets you have been having. So it is a technology that does not require massive investment. That's why I can confidently cap that for the next 1 year or 1.5, we need not more than $3 million to support the TA. And in country, we have got partners who have aligned themselves. They have aligned themselves to this technology. They have already invested in it, and we share the costs. So they have shared costs of technology, getting the scanners, getting the computers at the higher level. But all we need is the TA to work with us as we work on capacity build and working on technology transfer.
Yeah, absolutely. I agree with everything you've said. And I'm very excited to the next steps and what SPT will bring into the program and even beyond.
Yeah, for me, I have no doubt in my mind that the choice is right. And just like any other technology, we need to be assisted to work with it. And as we used SPT for COVID-19 mass vaccination, we had the technical teams who worked with us, were able to digitize, were able to provide vaccination certificates to people. And that was the first time we put this system to a large scale use under emergency settings, and it delivered us. What about only vaccinating few people in a year? How would this be difficult?
Yeah, absolutely.
So it defeats logic. So this is my conviction, and I think that we have the solution to digitize our immunization system, and we need to mobilize people who have resources to support the process if they are really speaking for improving immunization services and doing improving immunization services and reaching 0 dose.
Yeah, and I hope that I can help with that.
I trust you.
I'll try my best. No, but this has been great, Dr. Alfred. I really enjoy listening to you because you have a lot of valuable insights, and I think it's important to bring these to awareness of people that do have those resources. So
yeah,
thank you so much for dedicating your time. I know that you're very busy, so I really appreciate it. And
all right.
I'm looking forward to any other session, any other discussion, and yeah, let's work on it to make it happen.
All right. Thank you. Thank you. I look forward to the next mission. Yeah.
Yeah, me too. Us too. Thank you so much and have a nice day.
Same to you. Same to you. Thank you. Bye-bye.
Bye-bye.